Hit the subscribe button or visit us at auau.auanet.org.
Good morning, everyone, or afternoon or evening, depending on where you're joining us from. I'm Matt Nielsen from the University of North Carolina, currently serving as chair of the AUA's Quality Improvement and Patient Safety Committee. Thank you for joining today's webinar, Building a Primary Palliative Care Model for Urology. This webinar is part one of the AUA Quality Improvement Summit. We will share additional details on the second webinar and the in-person session at the conclusion of this webinar. Before we begin the webinar, I will run through some important housekeeping items. The AUA is accredited by the Accreditation Council for Continuing Medical Education to provide CMEs. This webinar qualifies for a maximum of 2 AMA PRA Category 1 credits. Here are the learning objectives for the webinar today. If we can go back a slide, 1 second here. Sorry, a little technical difficulty here. Okay, there we are. All presenters and planners have disclosed any conflicts of interest prior to the participation in this webinar. Each faculty's COIs can be found on the course page on the AUA University website. Again, here are the learning objectives for the webinar today. At the conclusion of building a primary palliative care model for urology, participants will be able to identify the optimal timing, provider, and support required to support the needs of patients with advanced urologic disease, describe the settings in which goals of care, prognosis, diagnosis, advanced care planning, goals of operations and procedures, and physical and psychological symptom management are currently being pursued, explain methods of family engagement that support both the family and the patient as disease progresses, discuss aspects of patient care and counseling lacking within current health systems, and assess the spiritual and support needs among patients with advanced urologic health conditions, the point along the disease course when this support should be offered. I'm pleased to introduce the course directors for this webinar. Jonathan Bergman, MD, MPH, is an associate professor of urology and family medicine and associate program director at UCLA. As the chief of bioethics at the West LA VA and the chair of the Urology Primary Care Work Group at LA County DHS, he has an interest in health systems, population health, medical education. He also works on integrating palliative care into the management of urological patients to address the needs of patients with advanced disease. John Gore, MD, MSHS, is a professor in the Department of Urology at the University of Washington School of Medicine and affiliate investigator at the Fred Hutchinson Cancer Research Center. He is program director for the University of Washington SUO Fellowship in Urologic Oncology. His clinical expertise is in urologic oncology. His methodologic expertise is in health services research, including surgical outcomes research, patient-centered outcomes research, comparative effectiveness research, and quality of life. Here are the faculty for today's webinar, and I'll turn it over to Drs. Gore and Bergman.
So it's my honor to introduce Kelly Farrow for our first talk. Every year we get about 300 applications and we read them all really, really closely, hoping to find one Kelly Farrow. Dr. Farrow is a superstar. She did her undergrad work at Stanford, where she was a Division I rower. She then attended UC San Diego on a merit scholarship. As a resident, she's been remarkable. She's in the rarefied air occupied by previous residents like John Gore, Aaron LaViana, and very few others. Dr. Farrow is also an avid surfer and a new-ish mother to baby Lola. And she's actually already done work on the evidence we have about subspecialty-based primary palliative care. Dr. Farrow, the floor is yours.
Thank you so much for the kind introduction, and a special thanks to Doctors Bergman and Gore for their mentorship and guidance putting this presentation together. I'm excited to provide a brief overview of the evidence for subspecialty-based primary palliative care. Many of us are aware that the US population is aging, and as the US population ages, so does our urology patient population. In general, as we age, our serious illness burden increases, and the absolute number of patients with palliative need increases. An important distinction to make early on, and one that's often lost on patients and providers with less education on the topic, is between palliative care and hospice. There's much therapeutic overlap. However, palliative care can and should be provided at any stage of a disease process and in a concurrent fashion with active treatment. Unfortunately, a detailed review of the case for palliative care is beyond the scope of this presentation, but overall, the case is well established for providing palliative care services. They've been demonstrated to increase quality of care and patient satisfaction while decreasing utilization of costly services. With that background, I'm sure that many of you, like me, are thinking that this sounds great. We should refer all our patients with palliative needs to a specialist in the field. However, there are not enough specialist palliative care providers to meet the needs of all patients. So, how can we help meet our patients' needs? We should consider the providers available in the US at present capable of delivering palliative care. There are palliative care specialists, of course, who deliver services in the hospital, in clinics, and in home-based programs, but they're relatively few in number. More accessible to many patients is the primary care workforce, who can provide services in a clinic or in home-based programs. Relatively new to the mix are non-palliative care specialists, your cardiologist, pulmonologist, urologist, who see patients in clinic with significant benign and malignant disease burden with opportunities to improve patient care by layering in palliative services. So in preparation for this discussion, we sought to investigate how this is achieved in the real world. Are non-palliative care specialists successfully providing palliative care? To answer this question, we conducted a systematic literature review. First, of primary palliative care delivered by general practitioners, and second, primary palliative care delivered by non-palliative care specialists. The body of literature on primary palliative care delivered by general practitioners is immense. We reviewed 14 systematic reviews, and they focused on a number of distinct subtopics. There's good evidence describing how to identify patients with palliative care needs, models of care delivery, barriers and facilitators to delivery of care, patient outcomes, how to evaluate providers, and the experience of both patients, providers, and their caregivers. These decades of research can and will serve as foundational work to build and improve our ability to deliver palliative care services to our urologic patients. In contrast, the available literature on subspecialist provision of palliative care services is more scarce. Of over 4,700 abstracts reviewed, only 10 met inclusion criteria with widely variable methodology. While these studies reported on provision of palliative care services among a number of specialists, surgeons were underrepresented. There were studies on gynecologic oncologists and trauma surgeons, but they were certainly the minority. So with this information, where do we go from here? You might be wondering what to do on Monday to help your patients with palliative needs. I think the path forward has really been paved by our general practice colleagues, and we have an opportunity to fine tune and perfect the care we provide with our understanding of the nuance of patients' urologic disease and within the unique constraints of our busy surgical, clinical, and operative practices. So we plan, we educate providers, we determine the scale of whatever our initial endeavor is to prioritize palliative care in our urology practices. We do. We implement. We implement well-described strategies with a track record of meeting patients' palliative care needs, build off of years of work done in primary care space to streamline implementation in the subspecialist space. We study every step of implementation. We track patient satisfaction, track symptom control, track outcomes, cost, utilization, place of death. And then we act. We refine the delivery. We start at the beginning and improve with every iteration. So in conclusion, I'll leave you with our nascent conceptual framework of providing palliative care to urology patients. In the figure, graphically represented is the burden of needs of a hypothetical patient over time. The urologist is well positioned to initiate palliative care delivery. We have an expert understanding of disease prognosis and side effects of treatments and interventions. We need to focus on effective communication, ask specific questions about symptoms that impact quality of life, and initiate advanced care planning routinely as our standard of care. Over time, our patients' needs will likely exceed our abilities to meet them, either from a medical knowledge standpoint or a pragmatic standpoint, given the structure of a surgical practice, at which point we begin to integrate our services with those of our palliative care specialist colleagues. The final point I'll make is that many of you, whether you recognize it or not, are providing some level of palliative care as part of your everyday patient-centered practice. What we must do moving forward is to provide additional education, resources, and support to operationalize even more impactful service provision.
Kelly, that was incredible. Thank you. I think this is going to dovetail well with Dr. Carl Lorenz. Urology was introduced to Dr. Lorenz kind of by luck about a decade ago. We submitted a grant to the American Cancer Society, and the grant got rejected. And in the rejection letter, it said we needed a better mentor and that the best mentor would be Carl Lorenz. Dr. Lorenz is currently at Stanford and the Palo Alto VA. He has way too many leadership positions to list, but Dr. Lorenz is the premier palliative care researcher and mentor in the country. He's mentored every single person who's doing work in the field. And over the past decade, he's donated of his time very generously to helping us in urology. I think Carl is that very rare person who is more invested in other people's success than in his own. Dr. Lorenz is also a singer and an instrumentalist. So Carl, we hope to get you on stage at the AUA in September to show off your chops. The floor is yours.
Thank you, John. That was a very kind and over generous introduction. And I just want to thank everyone else on today's call. We have such a talented and innovative group, and it's a real honor to be a part of it. I'm going to talk about the aspects of palliative care that most benefit patients. And I want to, in particular, focus on key benefits of palliative care and the aspects of palliative care evidence that are especially important in the surgical context. Let's see. Sorry, I'm trying to get the screen to move. I'm going to start with a story. And this is a story of a patient who came to see me in Los Angeles. It was a very important learning experience for me as an internist who was becoming increasingly interested and involved in palliative care. This was a drawing that was delivered to me at the time that this patient presented. And the patient had come from a surgeon. He was referred to the surgeon because of extreme pain related to a lump along his neck. He was having pain across his neck and the side of his face. The surgeon did a very competent evaluation and proposed a course of tests and a return to clinic for evaluation for what was likely a head and neck cancer. The importance of this story for us today is that the patient never went back to the surgeon. This was a heartbreaking case of a gentleman who went on to die of a curative, highly curative head and neck cancer, because when he came to see me, he was incensed that the physician he had just seen 10 days ago failed to address the pain that he was experiencing and the reason that he had sought follow-up. The patient's pain was manageable, but we were unable, through extensive conversations, to get him back to surgery. He simply told us, quote, "I'll never trust a surgeon again." And that's a reminder that good surgical care begins with the patient and begins with the complaints and concerns of the patient. And the concerns relate to the impact of disease on their lives, and not just the disease itself. Let's see. So we've already heard a little bit about palliative care, but what is distinctive about palliative care? I'd like to remind you, our understanding of it is derived from excellent work characterizing the impact and concerns of illness that patients and families have. And palliative care focuses on support for seriously ill patients and their caregivers because patients care deeply about the impact of their illness on their loved ones. It addresses physical, emotional, social, and existential aspects of illness and treatment, and indeed may be one of the only spheres of medical practice where we care deeply about the existential concerns that patients have about their illness, and it's explicitly a focus of our care. It involves, for the surgeons, importantly, proactive identification, communication, and management related to the patient's prognosis, personal goals, treatment risks and benefits, pain and symptoms, which frequently accompany nearly every illness eventually, and caregiving needs. And because of these dimensions of palliative care, it's interdisciplinary in nature, and teams, although not formally structured this way by any regulatory environment, et cetera, it often includes social workers, chaplains, psychologists, pharmacists, and other team members as essential parts of the care team. So in the surgical context, how do we think about the benefits of palliative care? Again, in terms of seriously ill patients and caregivers, who are they? And I'd like you to think about two categories of seriously ill patients. One is the patient facing a life-limiting illness. And my concern here is to help you understand that in some examples like dementia, life-limiting illness can be 8 to 10 years from the time of the initial diagnosis. And in terms of a patient and family's agency to make choices that reflect their goals, in an example like dementia, it's essential to recognize that ongoing peril of cognitive impairment from its onset before the patient's agency and contribution to their own goals is removed by the illness itself. In the case of cancer, things tend to be relatively short, but the value of palliative care and what it can bring to care extends along that entire continuum. In general, the other category in which we need to think about it is serious illnesses when patients experience serious impacts, both of illness itself, but also its treatment. Systematic proactive identification is critical in the surgical and medical context because many times we cannot see the vulnerabilities that patients bring to the visit or to the encounter because they are so manifold and their cumulative effects may be inapparent to us. So there are several approaches one can take to this in the clinical setting. One is to apply a rule, and another, of course, predictive models and analytics are more and more common. But there are also screening approaches. The risk assessment index is one that I've become increasingly familiar with, but Dr. Suskind has done some excellent work, actually, we'll be talking later, reviewing these measures if you're interested in them. In medicine, one of the common clinical measures that's used is, would you be surprised if this patient were to die next year? So there are a variety of approaches that one might take to identifying patients, but being systematic and proactive is particularly important. And I'm not going to answer this question, but based on that, when is a patient in urology seriously ill? And I think there are many possible ways of thinking about the specifics of different conditions. So what's the evidence for palliative care and surgery? Frankly, it's sparse. We've kind of already heard that. And it may be sparse, but it's still important. There has been work looking at this intersection. And I picked two published studies that I think are particularly salient. One was some quality improvement work that was done by Dr. Jason Johanning in Nebraska. And a quality improvement intervention of systematic frailty screening and multidisciplinary case review was able to reduce mortality for frail individuals, importantly, also for non-frail patients, and also increased at the same time earlier palliative involvement. Only 4 patients had to be treated and assessed in a multidisciplinary sort of surgical tumor board of sorts to avoid 1 death among the most frail patients in the study. Importantly, the benefits of palliative care may be similar in surgical as well as medical patients. Our review, looking at after-death reports of patients who had died following surgery, showed that overall end-of-life care communication and practical support were all improved by palliative intervention. So when to consider palliative care? Risk identification and management in the context of the surgical decision-making with the goal of ensuring the right treatment and care for the right person. When health-related quality of life is threatened by the illness or treatment, to help patients live with better and adapt to illness and its consequences. And at times of transition and end-of-life care management. So this is when things don't go well. And there are several categories of this. One, of course, being when the patient is approaching the end of their life, as in the case of advanced prostate cancer, but also when multimorbid disease is taking its toll or surgery doesn't go well, and patients need transitional support, care coordination, and follow-up in their transitions to home as a place of final care. So I just want to close by reminding you that there are many options. These are early days in terms of our consideration of the intersection of these modalities. There's much promise that they're beneficial, but I would say let your consideration begin with your own learning, and participating in this is certainly a worthy way to begin that process. But I would refer you to things such as EPIC, which are generalist approaches to learning many of the skills, including treatment of relatively straightforward concerns that many patients have. As my opening case illustrates, having some capacity in your own practice for these approaches does have value. And thank you very much.
Thank you so much, Dr. Lorenz. I don't see any questions in the Q&A, and I think in order to, I take that back. Actually, we just have one question that came up. Dr. Lorenz, how do you broach the topic of palliative care if someone has an expected lifespan of about 10 years? This person is thinking of a patient with newly diagnosed metastatic prostate cancer who's only 60 years old.
That's a really great question. And of course, you know, I think that I might ask a question. One that I've taken to asking recently is, have you ever lost anyone that you love? By the time we're in our 50s, almost everyone has. And sometimes I will ask a patient, are there important lessons that you've drawn from the experience of being involved in that person's life beforehand? And sometimes that's a way to approach the topic when it's otherwise intimidating. But the most important issue is to simply ask what's important to the patient to help understand what drives their perspectives and goals. Many times they don't have specific end-of-life wishes. In dementia, of course, as in other conditions, I always try to keep in mind that the issues to tackle are the ones that are most likely to face the patient in the short term. And so in urology care, that might be, for example, a surgical intervention and whether it's appropriate. So you want to keep in mind that not asking about everything is not always necessary at any particular junction, but everybody has drivers of their goals and preferences that can help us interpret the value of treatments down the road. And many times I will actually address the issue of sort of what are the fundamental or minimal quality of life goals that the patient would have if something catastrophic occurred. Understanding who their proxy is for getting through difficult situations and for communicating around things is an absolutely essential issue. And having that conversation with that person in the room is critical because 50% of the time people name someone but actually don't discuss these issues with them. So those are some things to keep in mind.
Thank you so much. We're going to take some additional questions at the end of the next two talks. I have the distinct privilege of introducing Renata Lauwers. I have been fortunate to know Renata for about 5 years now. She's a writer, editor. She co-founded Months to Years, which is a literary journal that uniquely explores issues of grief, loss, death. And she herself was a caregiver to her first husband, Ahmad Khashru, who unfortunately lost his life to bladder cancer in 2014. Her experiences as a caregiver to him uniquely reflect many of the challenges that caregivers face, many of the challenges that we all face in navigating the end of life. Her advocacy work has included volunteer work with the Bladder Cancer Advocacy Network. She's worked as a volunteer peer facilitator for ANCAN's virtual support group for advanced care caregivers. And she also works with me as part of a PCORI grant that compares 2 treatment options for recurrent bladder cancer. She's been published in numerous platforms, including the Philadelphia Inquirer, Stat News, and most recently Intima. And she's going to share her perspective with us on how doctors can best support patients at the end of life. Thank you so much for being here, Renata.
Thank you so much, Dr. Gore. And I want to just say thank you to the AUA for including this caregiver perspective in the conversation today. I also just wanted to say we had exceptional access to palliative care when my first husband was ill, and it made a tremendous difference in our quality of life. He had pain that required very nuanced management, and the palliative care folks were fantastic. So just my plug there for palliative care. I'm going to read the essay that was recently published in the Intima. And this is in the context, we had been receiving palliative care. This is at the last few weeks of his life where we had transitioned to hospice. And this is called, "We Can Offer You Some Helpful Resources." Teetering on the cusp of widowhood at 45, I realized my intensity had sent the hospital social worker scurrying away. Ours had been a tense and circular conversation, littered with euphemisms by her and rage by me. She had initiated the conversation by saying she understood how tough the journey had been. She continued on about the discharge protocols. "I can't take him home," I protested. "I can't care for him at home." As if to prove that I actually could care for him at home, she noted that the care team has already signed off on his discharge, and she was just awaiting the paperwork. The team would, she assured me, do all they could to support this transition. I told her that unless the team was coming home with us, I could not care for him at home. "A hospital nurse will follow up in the morning by phone," she said, "and the hospice nurse will visit daily." "Phone calls and a daily visit aren't enough," I said, struggling to contain my anger. "We already tried at-home hospice, and that's why we're here. He is bedbound with a catheter, groggy, in pain, and running fevers. How do I give him pills? How do I give him water? And why is it my job to learn how to manage a catheter?" A woman in royal blue scrubs arrived and handed the social worker several loose papers. The paperwork just came through, the social worker said. Through many hospitalizations of family members, I had never witnessed a speedy discharge. Yet the one time I opposed the discharge, the bureaucracy buzzed with efficiency. I recognized that the social worker meant well, but I lacked both the stamina and the skill to care for my husband at home. She bore the brunt of my exasperation. My husband suffered from sepsis, as well as metastatic bladder cancer that had been advancing for a year. If he didn't receive precise pain management, his pain escalated to intolerable levels. As his sole caregiver, his family lived halfway around the world, it all fell to me. Would a doctor in the hospital ever recommend a bedbound and groggy patient try to swallow Tylenol or liquid morphine while lying down? No, because of the risk that the patient might aspirate. But they were willing to send a caregiver/wife home to muddle through. My conversation with the social worker ended when she inadvertently revealed the real reason for the speedy discharge. "We need the bed," she said. I stared at her. I interpreted her statement to mean they needed the bed for someone they could fix. "We're not leaving because I can't care for him at home by myself," I repeated. "A nurse visiting once a day is not enough." The care team had visited me earlier in the day to explain that they did not believe they could do anything else to help him. They had spoken to me as if I did not understand or recognize this. It was clear to me that my husband was dying. It was not clear to me how I was supposed to care for him until he did. And no one at the hospital had offered practical help for that problem. Previous social workers during previous hospital stays had handed me lists of home health agencies with titles like helpful resources. Buying your way out of a problem is always an option, and buy it to the extent we could, we did. For $25 an hour, a home health aide with a few weeks of training would show up and help us out periodically. But here's a major problem with home health care. A caregiver often needs significant help at specific times of day for specific tasks. These tasks might total 2 hours over the course of a morning and afternoon. But home health agencies typically require a minimum purchase of a 4-hour shift. This makes sense from the agency's perspective, but a family buying the care often ends up paying for hours of help it doesn't need. In the quiet, after the social worker left, I cried as I stared down at the hospital's speckled linoleum. During the prior year, we had ricocheted from crisis to crisis. The Ivy League educated doctors could not fix him. I had raged in waiting rooms about oncology flyers touting early detection. His bladder cancer had been detected early, before it spread. It had been treated. He had been deemed cured. And then 2 years later, it had returned as metastatic. Even as a well-insured, upper middle-class couple in a progressive American city, we could not afford to fully buy our way out of our home health problem, nor could we navigate the healthcare system without frustration. What must this be like for those less privileged? My rage felt bottomless regarding the platitudes, the feigned empathy, the references to the journey from one too many nurses. Sometimes I raged in solitude. Sometimes I raged to their faces. I knew I viewed them unfairly sometimes, but it felt like the larger medical system kept creating infuriating obstacles, and that kept me stuck in rage. I found solace during that year in a writing group for cancer patients and caregivers, offered twice a month at a major university cancer center. I found it to be the only place where I could express the raw and painful reality of my life, and I did not feel compelled to offer a trigger warning, as I so often did in other settings. Advanced cancer caregiving is a lonely venture, especially at an age when friends are raising kids, not caring for dying spouses. I enrolled in an online class that focused on the work of Louise DeSalvo and writing as a means for healing trauma. I wrote and wondered why the world at large failed to give voice to the many challenges we encountered. An hour or so after the first hospital social worker left, a different one appeared, accompanied by a doctor I had never met. They said they had been brainstorming a solution. They said my husband could be transferred to the Zen Hospice Project and cared for at a reasonable price. I had heard of San Francisco's Zen Hospice Project, but knew little about it. Although the new social worker had already lined up transportation for my husband, I insisted on visiting before transferring him. 30 minutes later, I crossed the threshold into the serenity of what felt like a Victorian bed and breakfast in San Francisco's Hayes Valley. Fresh flowers splayed across the mouth of a giant vase near the front door. The curved staircase with its intricately carved wooden banister harkened back to the 19th century. The sunlight through the bay window created shifting parallelograms on the wood floor. I knew this was the place. The not yet nationally known Dr. B.J. Miller sat with me a few days later as I struggled with my husband's original wishes to do everything. He offered to make the tough call for me regarding a DNR order. He explained that California law allowed a doctor to decide on my behalf. His compassion and the relief it gave me felt like an alternate universe compared to the medical system in which we had been mired over the prior year. Each time I arrived at the guest house, as it was called, a volunteer asked me what she could make me for lunch. Homemade soups and cookies and flavorful sandwiches flowed from that kitchen. I regained the appetite I had lost months earlier. The volunteers told me I could finally be a wife instead of a caregiver. My husband died at the guest house after 2 weeks there in late April 2014. Witnessing the serenity of his time there, my octogenarian mother asked, only half joking, if it was possible to make an advance reservation at the guest house. A few years after my husband's death, the guest house and my cancer writing group both also died from complications specific to their circumstances. 7 years later, I still wonder why the compassion we experienced at the guest house felt so uncommon in a system that claims its highest priority is providing care. The end. Thank you so much.
Thank you so much. I'm going to turn it over to Dr. Bergman.
Renata, that was so powerful, and I think a call to action for all of us to do better. And we're hoping that we can use this summit to try to do a little bit better than we currently are. So our interest in primary palliative care started with a project we did with Dr. Lorenz about a decade ago, where we looked at hospice utilization in men dying of prostate cancer. And we saw that we weren't doing very well. We were using hospice about 30 to 60% of the time, and we weren't using it for the correct time period. When we looked at what we were doing to these patients at the very end of life, we were being really, really, really aggressive with what they were getting in the very end of life. We were doing a ton of outpatient visits, a ton of imaging, chemotherapy, radiation, inpatient visits. And what became clear to us when we looked at the hospice use was that the answer definitely lay upstream. We needed to do a much better job earlier on asking patients about their preferences and about their needs. The next question was then, who knows them best? Why should a urologist do palliative care? We spend all these years becoming surgeons. We get good at surgery, hopefully. And who is it who should be doing these assessments earlier on in the disease course? When you start thinking about it, for all of our patients with advanced disease, whether it's a patient like Renata's first husband with metastatic bladder cancer, or patients with advanced stones or advanced FPMRS problems or general urology problems, the urologist is the one who's known them the longest. We know our patients for 10, 15, 20 years. And by the time they get to advanced disease, we really are the ones who know them best. So if we're going to invest in doing better with their palliative needs, I would argue that we are the ones who should be leading that charge. Now, every agency agrees that there's a huge benefit to patients getting palliative care. Clearly for Renata and her first husband, if they had been referred earlier on 2-3 years before that time in the San Francisco hospice, there could be better interventions to give them better care. The problem is that all of our organizations, the AUA, ASCO, the Institute of Medicine, the geriatric societies, they say palliative care is good. Therefore, take your patient with advanced disease and refer him to a palliative care doctor. Those recommendations are made without really considering the resources we have. We only have about 4,400 palliative care doctors in the entire country, and we have 11,000 unique deaths every year in Medicare alone. So clearly, if the answer is going to be take everybody with advanced disease and refer them to palliative care, that's not going to succeed. And it hasn't succeeded in urology. So we have these guidelines. We say refer everyone to palliative care. But if you look at our patients with cancer, for instance, whether it's prostate cancer, bladder cancer, kidney cancer, at most about 20% of them get palliative care. And that's not surprising if you figure that our model to date has been refer them to palliative care, but we know that resource-wise, we don't have enough palliative care doctors. So we think that part of the solution is primary palliative care. We've piloted this at our West LA VA, which I think is the biggest VA in the country. We started with an intervention that was very straightforward. It involved three things: an educational module, palliative care integration, and point of care reminders. We started with qualitative work because we wanted to understand what people thought about this. And almost all of our trainees were interested in doing better for patients with advanced disease, but they clearly said that they needed more education. This is one sample quote of someone who said, "I don't play a role of end-of-life care, but I want to. I need to be taught and shown the right things to do." We therefore built an educational module. It's very straightforward. It's web-based, takes about 10 or 15 minutes to complete, and it walks a clinician through a patient with a stage 4 bladder cancer, and we talk about all the things that should be done for that patient during a clinic visit. The second piece of our intervention was point of care reminders in the electronic health record. It was a reminder to discuss prognosis, to discuss goals of care, and to place a palliative care consult. We want to make sure that someone addresses pain, addresses depression, family support, talks about advanced care planning, hopefully codifies that in the form of an advanced directive or a post. And then finally, we took everybody with advanced disease and referred them to palliative care early in the disease course. So as soon as they had advanced disease, they started to be co-managed by urologists and palliative care doctors. What was really interesting was how this evolved over time. At the beginning of the intervention, a patient would get referred to palliative care, and the palliative care doctors would do all of the supportive care. What happened over time is, as our urologists saw what palliative care was doing, they started doing a lot of the symptom assessment themselves. So the urologists were asking about pain, asking about depression, asking about family involvement, asking about goals of care. And it really evolved over time where the intervention at 5 years looked very different than the intervention at 1 year. And I think that's maybe representative of how a primary palliative care model may mature over time. When we looked at our educational module, it actually changed people's attitudes about care priorities, and those changes were durable over time. So after doing the educational module, people thought it was more important to ask about pain, to ask about goals of care, for patients to die at home. It also changed their knowledge about end-of-life care. And again, this was durable over time. Things like their understanding of advanced care planning, quality of care indicators, cost. So what that showed is a very straightforward, limited intervention to educate people about palliative and end-of-life care can really change people's knowledge and attitudes. We then circled back and did another round of qualitative work because we wanted to make sure that we're not imposing on people an intervention that they actually didn't like. The biggest concern at first was time. People were concerned that it would take a 20-minute clinic visit and suddenly make it 45 minutes and kind of ruin the clinic flow. When that didn't happen, everybody realized that this was a good thing and that it was a massive benefit to our patients. One sample quote was, "Once the palliative care team got involved, it was miraculous how his pain came under control. It was significantly better for the patient." A few other outcomes from our integrated clinic: hospice utilization was around 81%. Again, in the community, it's about 30 to 60%. Quality of life was maintained. We know that for most patients with advanced disease, their quality of life decreases over time. Patients loved it, so patient satisfaction was very high. One area where we still failed was depression. About 43% of people in our intervention had moderate or severe depression. We know it's about 40 to 45% in the community. And, I think about all the extensive work we do to extend people's lives by weeks or months or many months. But if they're living those many months with moderate or severe depression, they really are having a pretty low quality of life during that time. So in my mind, this is pretty low-hanging fruit that we need to not only assess depression, but do a much better job of treating it for people with advanced disease. Almost all of the people in our intervention had advanced care planning. Some had an advanced directive, some had a pulse, some had both. But what was really interesting was when we delved into this a little bit more deeply, when we read through their advanced directive, when we read through their pulse, and we saw what their preferences were, nobody wanted super aggressive care at the end of life. Nobody wanted CPR, artificial nutrition if they were at the very end of life. And what that showed us is if you do primary palliative care the right way, if you ask people ahead of time, if you involve their families, what results is not death panels. Everybody can get all the aggressive care they want. And all we're doing is making sure that none of it happens by inertia. So we think that primary palliative care is ready for prime time. We hope to use this QI summit both this week and next week, and definitely the in-person summit in September, not just to talk about palliative care, but to figure out together how we can implement an intervention broadly throughout our field to benefit our patients. Thank you. And now we have about 8 or 10 minutes to take some questions for our audience. Renata, I had one question for you. You talked about kind of the inappropriate questions and assumptions about the care you would want in the hospital. What would have been the best way to prevent that? How could you and your husband's needs have been assessed and addressed earlier ahead of time so that I'm sure the well-meaning social workers and discharge planners treated you guys in a way that was more in line with what you needed?
Yeah, I mean, so he was diagnosed about 11 months with metastatic disease, about 11 months before he died. And we actually did get referred to palliative care fairly early in the trajectory. One thing I wanted to note was it was actually, and part of this was we jumped around from different medical systems, so it's hard to kind of isolate it, but it was really hard initially to get referred to palliative care, though. For some reason, the urology, it felt like, we're treating the disease, here's what we're going to do, and the problem we were facing was he had pain that was really hard to manage. And it wasn't until we got to those palliative care, that expertise where we could go to an appointment that was solely focused on pain. It had nothing to do with disease. We're not talking about CT scans or, immunotherapy trials or whatever. It just was pain. And that's what was really helpful. The reason we ended up, in the essay, we ended up back at the hospital. So he had actually been on home hospice towards the end. We ended up back in the hospital, though, because I couldn't cope at home. I just couldn't handle it, even with the visits and so forth. And so that was the point of the essay. But I also think it's really important, and I love this idea of a primary palliative care model. I think it's fantastic. I think it's really important, though, on the patient and caregiver side to educate people. And I know that within the circles of palliative care and the medical circles, we understand this, but the difference between palliative care and hospice, palliative care is not end of life. It overlaps, but that's not all it is. And I think getting past that stigma is huge. And even, and I also felt like often part of the reason it was hard to get that referral for us to palliative care is I even felt like some of the doctors kind of almost viewed it as like they were failing, they weren't succeeding if they referred us. What was the sense I got? I'm not sure if that was accurate, but I just felt like, why is this so hard? Like, we just want some pain management. Can't we go over there and get it? And it felt very kind of turf-ish, was my experience. So. I don't know if I answered your question.
No, absolutely.
I have a question from the audience for you, Dr. Bergman. Is the educational module you referred to in the West LA VA study, is it available for public use?
It is. I will find the link and I will send it around. Dr. Lorenz and Dr. Farrell, I have a question for the two of you about the current state. Carl, from your perspective, do urologists send these patients to you and then collaboratively take care of them? And Kelly, from your perspective, are you able to easily get your patients into palliative care? And how does that collaboration look after the initial referral? So the current state.
Yeah, so good question, John. I think that we're in early days in understanding what that collaboration or integration means. We do, of course, see these patients, how they get to us, like, for example, advanced prostate cancer, I think is somewhat circuitous and not always clear exactly. You know, patients sometimes wind up having a medical misadventure, a fracture, or present to the hospital with failing function. I think none of us in internal medicine or in urology and other surgical disciplines are sufficiently proactive on a systematic basis. So we find that there is collaboration, and we're doing some work right now to understand some of that. But I think it's kind of ad hoc, and a lot of it is developed in local hospitals through what are serendipitous and positive interpersonal relationships. You know, I'll never forget the very, very early days when I was actually back at the West LA VA. And I remember, this is not a surgical example, but it was before, I don't even know if we called it palliative care then, but you know, I remember going to see a patient who had advanced cancer for whom a feeding tube had been ordered. And the gastroenterologist felt a lot of moral distress at having to put in a feeding tube in a patient who was close to the end of life. And I remember a simple conversation with the patient to understand what they really were after in life helped us to make to provide the right kind of support at home so the patient could accomplish what he had in mind at the time. You know, that made an enormous difference in the eyes of that gastroenterologist, who then became quite an advocate for taking these approaches with some of these patients. So I think those interpersonal relationships are not to be minimized, right? Those small demonstrations of effectiveness can have a big impact on the long-term well-being of those kinds of demonstrations. But we need to do better, and mostly through systematizing.
This is a question for, I believe, Carl and Dr. Bergman and Dr. Farrow. Is there sort of a precision medicine analog for palliative care where you can have sort of more of a patient-specific application of the palliative care model?
I think that there certainly could and can be, and it may be something worth, you know, working towards. But I think one of the important points to make is that really anyone can deliver palliative care and primary palliative care and meet many needs of many patients without getting quite so technical, I guess, is a way of thinking about it. I think that, you know, we use this term primary palliative care, specialist palliative care. I really just want to make the distinction that primary palliative care is almost like this bigger umbrella. And then within it, historically, general practitioners have provided a lot of the services when patients aren't able to get to a palliative care trained specialist, or before that was even a board certified thing. But really, it doesn't have to be a GP. It doesn't have to be an internist. We all should, as part of our patient-centered care, be asking questions. And I think the distinction between and managing these problems, and I think the distinction between you know, treatment and addressing palliative needs is really an
So
this if you ask and address cancer pain.
So I think that's a great question, and I'd like to propose getting rid of the term precision medicine. What I mean by that is I really think we should have a term called precision care. And you know, in biology, precision medicine is a very important contribution to understanding the incredible diversity, right, which underlying biological attributes contribute to illness. And you know, if we have 100 genes, the combinatorial possibilities are immense, right, with regard to individual expression. But what we fail to recognize is that precision care recognizes that social determinants, a person's environment, their unique personal characteristics, their individual history, their family, their spiritual beliefs, their race, their ethnicity, their languages that they speak at home, all of these, like genes, affect the expression and impact of illness on our individual experience. And so rather than thinking about this as a biological phenomenon, we need to think about it as a personal phenomenon. And rather than just assessing the biological aspects of disease, we need to take seriously the need to understand the impact of illness and disease processes on the individual life experience. That's really the message of precision care, if I could put it that way.
That's a great point. Massive thank you to Renata and Carl and Kelly. I hope you guys are able to stay on because we're going to have a final Q&A in the end. And we hope that you'll be able to join for that. But thank you for your incredibly moving and meaningful talks about the current state of palliative care. And you've definitely highlighted the fact that we have a lot of work to do. We're going to now start our panel discussions about when palliative care is needed. And it's my honor to start by introducing our oncology colleagues, Dr. Jacobs and Dr. Gilbert. So Dr. Bruce Jacobs did his BA at economics at Amherst and then his MD at Vanderbilt. He did his residency at the University of Pittsburgh. He then went on to fellowship, but with very strict return instructions that he had to come back to Pittsburgh as soon as he was done with his fellowship. So he went to Michigan, did a fellowship in health services research and oncology, got his MPH. He was true to his word and came back to the University of Pittsburgh, where he is now. He's done a lot of wonderful work in improving quality access and delivery in geo-oncology. And he actually is one of the only people in our field who's done a good amount of work in palliative care. So we can't wait to hear from him about that. Dr. Jacobs loves to garden, but he says he's not very good at it. So if you see him at the AUA and he offers you a tomato, maybe have someone else taste it first. Dr. Scott Gilbert did his MD and residency at Columbia, followed by a fellowship also at Michigan in health services research and oncology. He's now a urologic oncologist at Moffitt and has done really transformative work in patient-reported outcomes and care delivery. Dr. Gilbert enjoys fly fishing and he plays classic rock guitar. So Dr. Gilbert, at the AU in September, maybe we can get you on stage to rock out with Carl. Gentlemen, the floor is yours.
Great. Thanks, John, for those kind words, and congratulations on the work you've done in this area of palliative care. I first got interested in this by our resident at the time, Lee Huger, who had a sense that there was a big need to look at this further in urology. And through his work, we realized that how underutilized palliative care was used, specifically in urologic oncology. And he looked at bladder cancer specifically and saw that it was used about 4% of the time. Lee Huger has now joined Scott down in Moffitt, is the oncology fellow there. So a shout out to him. Also, Renata, thank you so much for sharing your powerful essay. I think it really highlights a lot of the issues and needs here. And I think this case we're going to bring up pales in some ways in comparison, but Scott and I put this together to try to highlight where we can start thinking about using palliative care along the continuum of treating these patients. So we're going to present this case. This is a 68-year-old male with newly diagnosed muscle-invasive bladder cancer. He was accompanied by his wife to the appointment. When talking about his diagnosis and treatment options, it was noticeable that both the patient and his wife were tearful hearing about this. The patient's past medical history, which is not uncommon for someone with bladder cancer. He had hypertension, diabetes, COPD, and had a history of anxiety. His social history included that he was a smoker. He smoked about a pack a day. and he was an active farmer. I think this is a good time as a clinician to think about, potentially doing some primary palliative care, given the anxiety about the diagnosis. There's some tools that can be used to screen. I think this is a point where with survivorship clinics or advanced practitioners in clinic can also get involved to spend some time going over goals of care. I don't think this is a point where you would need to refer for palliative care, but certainly beginning stages of thinking about some primary palliative care.
Yeah, Bruce, just to pile on that comment. So a lot of cancer centers are moving to using distress thermometers or distress screening questionnaires at the point of care. So, at a new diagnosis of a aggressive cancer or any cancer, I think that's a useful tool that we've implemented in our clinics, and it brings to front of mind the experience that the patient and their caregiver are going through in terms of anxiety, and help screen in folks who might benefit from a conversation with social work or another resource, in addition to seeing the surgeon.
Yeah, that brings up a great point, Scott. And also, I think we should mention just in general for these oncology patients that we see in clinic, I think just having in our heads the option of palliative care, particularly in patients that present with more advanced disease, and the subset of patients with localized disease who have symptoms, particularly pain. So we'll move to the next slide here. So this particular patient elected to proceed straight to a cystectomy and an ileal conduit diversion. There were conversations about the pros and cons of neoadjuvant chemotherapy. This was getting into the active farming season, and he was concerned about time away from work, so elected not to do neoadjuvant chemotherapy and go straight to surgery. Next slide, please. So initially, the patient had an uneventful recovery. He did have advanced disease. His pathology was P-T3B, N1-MX, so he had some nodal involvement and had negative margins. Next slide. So he was doing well for a while, and 2 years later, he presented to clinic. He had some back pain, abdominal discomfort, poor appetite, lost 15 pounds over the last few months. And we obtained a CT scan, which showed concerns for metastatic disease to his bone, as well as a large pelvic recurrence that was really causing him a lot of pain. One of the basic pain management was difficult in the urology clinic. And so I think this highlights a time to really reach out to the palliative care folks to help fine-tune his symptom control, put him on a better pain management, and help monitor his symptoms. Because I think at that point, it can become difficult as a urologist to offer what the patients need. So in an effort to really try to treat this recurrence, he did undergo salvage chemotherapy, but didn't have a great response. There were discussions about proceeding with other treatments, including immunotherapy, but at this point, he really didn't want to proceed. And a couple months later, he died comfortably at home with his family by his by his side. All I'll say here is I think this slide, Scott and I kind of have on here as a cue to really kind of think about, transitioning to hospice care after, not wanting to proceed with other treatments, to really work on comfort, having the patient at home with his family, and really trying to minimize the discomfort from his symptoms.
Bruce, do you think that there were some social contributions to not only his medical management in terms of the neoadjuvant chemotherapy or lack thereof, maybe his decision not to undergo immunotherapy, but also pain management, or did that play into referral for palliative care in terms of access to the medical center or his work schedule, et cetera?
Yeah, I think that's a great point. At least the farmers that I've interacted with in Western Pennsylvania tend to be very stoic. They and some of the hardest working people I've come across, and really don't want things interfering with their work. So in outlining the benefits of neoadjuvant chemotherapy, to him, it was so important for him to be working that wasn't something that he wanted to do. And I also think that, I think he had a very, he was not a complainer. And so I think that we could have done a better job of intervening earlier to try to get him comfortable, because by the time he complained about his pain, it was really tough to manage.
Thank you both for that great case. Very illustrative. I think what we need to do is move on to some other examples of how we intersect with potential palliative care patients. And I'd like to introduce our next panel, which is going to examine cases that are pertinent to stone disease. I have the privilege of introducing Dr. Pearl, Dr. Lebert, and Dr. Scales. Dr. Pearl is a professor and vice chair of urology, but also duly appointed in internal medicine in the Mineral Metabolism Center at UT Southwestern. She currently holds the Ralph C. Smith Distinguished Chair in Urologic Education. Dr. Lebert is an associate professor in urology at Stanford, also staff surgeon at the Palo Alto VA, where he staffs multidisciplinary clinics in urologic oncology, but also caring for veterans with complex kidney stones. And Dr. Scales is a health services researcher, minted like myself and Dr. Bergman in the Robert Wood Johnson Clinical Scholars Program at UCLA, and currently a urologist at Duke University Medical Center. He's also PI of the Scientific Data Research Center for the NIDDK Urinary Stone Disease Research Network. Thank you all for being here, and I look forward to your discussion.
Thank you, Dr. Gore. On behalf of our panel, I'd like to thank Dr. Gore, Dr. Bergman, and the AUA for inviting us to participate in this QI Summit on palliative care. We don't typically think of stone disease in the context of palliative care because stone disease is one of the most common benign urologic conditions. And acute presentations of stone disease often involve pain, sometimes infection, and often the potential loss of renal function, so that treatment is often considered essential and not elective. However, there are circumstances for which treatment decisions about stone disease should be based on more than just anatomic or stone-related factors, and really need to take into consideration overall quality of life issues, as well as even end-of-life discussion. So in this spirit, Chuck's going to present a case of a patient with stone disease who doesn't actually have a terminal diagnosis, but who nonetheless belongs in this conversation about palliative care. Chuck.
Thank you, Dr. Pearl. So this is a 75-year-old female who was referred to my clinic with a large right staghorn stone after a recent hospitalization for urosepsis. And her urologic history was also important or notable for the presence of urinary incontinence as well. Her past medical history notably was quite extensive, and including morbid obesity. She was unable to ambulate without assistance. She was on home oxygen for COPD, had type 2 diabetes, a seizure disorder, obstructive sleep apnea, and resided in a nursing home. Our imaging demonstrated a 5-centimeter complete staghorn stone on the right, and her renal function was somewhat impaired with a creatinine of 1.6 and a GFR of 40. Dr. Leppert, what would your initial recommendations for treatment of a healthier patient with this clinical scenario might be?
Yes, thank you. I think this patient in a normal presentation would have several reasons for percutaneous nephrolithotomy as the primary treatment. The AUA guidelines suggest that increased stone burden, more than 2 centimeters, or the presence of a staghorn stone itself, like in this case, would suggest that PCNL would be the primary treatment for most patients. This is partly because staghorn stones can have significant sequelae and morbidity over time. So the risk of recurrent infection, loss of kidney function, and even mortality is raised when a patient has a staghorn calculus. And in historical studies, nearly 1 in 3 patients will eventually die because of a staghorn stone over 10 years. And the primary driver for this mortality risk is the development of serious infections over time. So for a typical patient, I think percutaneous nephrolithotomy and treatment would be indicated.
Thanks. How about the particular patient we're discussing here with her pretty significantly impaired health status?
Right. So I think because of her overall health, considering alternative options is important. I mean, the risk of a percutaneous nephrolithotomy is something to consider. Unfortunately, all of these alternatives have significant drawbacks as well. So, for example, we would not typically recommend shockwave lithotripsy for a stone of this size, in part because it's probably futile to expect that shockwave lithotripsy would clear the stone and eliminate the potential for infection, but also because breaking this larger stone into smaller stones may actually increase the risk of renal colic or future stone infection events. Ureteroscopy is another thing that we could consider with laser lithotripsy, and certainly this may be able to address the stone, but it would likely require multiple settings and multiple anesthetics. And during the procedure itself, with the increased renal pressure, there may be a risk of developing a more significant infection. So certainly a daunting task to consider ureteroscopy. The alternative of surveillance is something that we could consider. And so surveillance is suggested as an option by the AUA guidelines for patients that are asymptomatic. In this case, I think we can assume that the prior urosepsis event that drove the presentation is a symptom related to this stone. And the concern for repeated life-threatening infections is something that would typically drive us to recommend treatment, definitive treatment if possible. And then some palliative or maybe some less common alternatives first to consider laparoscopic or robotic surgery, even for a nephrectomy or a robotic pylotomy. These carry obvious risks themselves, and the patient's COPD and her baseline supplemental oxygen requirement suggests that she may not tolerate pneumoperitoneum for these type of procedures. And if you plug a patient like this into the NSQIP surgical risk calculator, you would estimate that this patient has a 1 in 5 chance of a severe complication after a nephrectomy and a nearly 50% chance in functional decline after a procedure like a laparoscopic nephrectomy. So I think that brings us to the more palliative options surgically of drainage of the kidney to just try to reduce the risk of severe life-threatening infections over time is another thing that we could consider. But this case brings up the obvious point why we're all here today, where given these complex decisions, it's probably critical that we rely on our colleagues to better inform the patient of our options and to discuss the risks and benefits of treating the stone and what these would mean to the patient.
Thanks, Dr. Leppert. I agree. It's really helpful in these cases, which are very complex, to obtain further input from other specialists, while at the same time directing the overall care. So given this particular patient's comorbid conditions, she was referred to a combined geriatrics anesthesia preoperative evaluation clinic that we have here at Duke. And basically their consensus was very much what you described here in terms of the NISQIP risk calculator, that considering her frailty and other medical conditions, surgical intervention was considered very high risk. And the consensus was that at a minimum, prehabilitation with pulmonary and physical therapy followed by reevaluation were recommended before any surgical intervention was entertained. But the most important thing was that during the discussion, the patient expressed a strong desire to really avoid surgery and to minimize her risk and to focus on potentially, trying to maximize her quality of life without risking the impact of functional decline, which again, you estimated about 50% for her. So we really decided at that point to focus our care recommendations on managing her urinary incontinence, which actually was the most bothersome urinary issue for her, her pain symptoms, and then minimizing the risk of recurrent urinary infections and urosepsis. So I think this case really highlights the importance of carefully considering the risks of operating versus the potential benefit for a stone disease, because, again, as Dr. Pearl mentioned, oftentimes we focus quite quickly and rapidly on the stone and minimizing the potential sequelae of that stone. But here, and particularly for this patient, it's really important to consider what is most important to the patient. And in this case, the patient's goals of care were really what guided the team's recommendation. And the decision was made to really focus on controlling the symptoms and the recurrent UTIs and minimizing procedural interventions. And in this context, as Dr. Lorenz said in a conversation we had earlier this week, it's really important to remember that palliative care does not only mean dying within the goals of care, but for many older adults, palliative care means living within their goals of care. Dr. Pearl, would you like to address question number 1 here? When should palliative care be initiated in stone disease?
I think it needs to be initiated really as soon as possible. I think once a diagnosis is made and surgery is being considered, particularly in a high-risk patient, such as in this case, we need to start thinking about overall quality of life and goals of care and how we're going to best achieve those, whether it's surgically or not surgically. In terms of aspects of palliative care that a urologist can implement, I think as urologists, we're really focused on maintenance of drainage of urine and, both internally and externally. And so much what we're involved in involves that, whether it's definitive surgical intervention or whether it's managing a problem less definitively, but just with the overall goal of improving quality of life. And that often involves drainage in some way, whether it's a stent, a nephrostomy tube, a Foley catheter, a suprapubic tube. And we have to think about how that impacts the patient, both doing something definitive to cure the problem, as well as how do we manage the problem if we elect not to proceed with a curative treatment. And we have to think about how much pain that involves, whether it involves an anesthetic, the difficulty of bringing a patient to a clinic visit or to the hospital, how it's going to be managed at home and who's going to manage it. Do they have to come to their clinic for tube changes? So I think all of those considerations have to go into our decisions as to how we manage the patient, particularly if we have to do something that will involve long-term drainage, as well as prevention of infection with long-term antibiotics and long-term pain medication.
Dr. Leppert, would you address question number 3 here for us?
Well, sure. I think just to echo what Dr. Pearl just said, we're experts in dealing with the details and the nuance of the management of the stone. And I think all the complex interactions of the stone diagnosis with the rest of the patient's health, but also the patient's goals, is where palliative care, I think, would be particularly helpful. So collaborating with experts in this area would give us a more complete picture of the patient's options and making sure we're selecting choices that are aligned with the patient's goals as well. So these could, involve care coordination, pain management, management of antibiotics, and also I think coordinating the types of interventions and what that means on a very practical level can be an important part of that discussion. So basically anything that would interact with our normal sphere of influence, I think is where this the role of palliative care in general, whoever provides it, would be particularly helpful for the patient.
It's a great point. And as Dr. Bergman pointed out earlier, we are oftentimes the folks that know these patients particularly well. And certainly in the case we just discussed, engaging pain management, infectious disease, and physical therapy was really an important focus for us to improve the patient's physical functioning. Geriatrics and primary care were also very helpful in terms of integrating management of the other chronic conditions that this patient had. And then, we felt that obviously urology would want to take a strong role in communication to coordinate if it became to the point of intervening with a nephrostomy tube, for example, and bringing interventional radiology on as a partner for the team. So.
That was incredible, team. We have a couple of questions, but I think we're going to do them all at the end just for timing purposes. So if you're able to stay on, I think around 11:40 or 11:45, we'll do all the final questions, and we have several for you. But that case was so illustrative of how important it is to assess our patients' needs. So our next topic is going to be FPMRS, and our speaker is Anne Susskind. Dr. Susskind earned her BA in anthropology at Haverford College in Pennsylvania. She then did her MD at Albany Medical College with distinction in bioethics, before continuing on to residency at the University of Connecticut, and then fellowship also at Michigan with in female pelvic medicine and reconstruction and health services research. She is currently at UC San Francisco as the chief of FPMRS, and she is a leader in our field in geriatric urology and has done really groundbreaking work in frailty and aging. For fun, she also volunteers as a winter wildlife docent at the Point Reyes National Seashore, and she educates visitors about migratory gray whales and elephant seals. Dr. Susskind.
Okay, thank you. And I think we'd like to start obviously by thanking Dr. Bergman, Dr. Gore, and the AUA for inviting us to speak and for organizing this fantastic webinar on this really important topic. So we're tasked today with talking about female pelvic medicine. And I'm going to start by just talking about the scope of the problem, focusing mainly on urinary incontinence today. So this is a hugely prevalent problem among people towards the end of their lives. And I want to highlight a couple of studies here. So first, there's this one study from the Health and Retirement Survey that included over 7,000 United States residents. And among people in the final years of their life, 43% who had cancer, 47% who had CHF and chronic lung disease, and 63% who were frail all had urinary incontinence. So you can see on average 50% of people in the final years of their life, the final year of their life. And the second study here was taken from a random community-based sample living in Sweden. And in the final 3 months of life, 56% reported urinary incontinence. So you can see these numbers are quite astounding. This is a study that was done in nursing home residents in Canada, and they were asked to kind of rank what were the most burdensome symptoms to them that they were experiencing. And you can see that 80% of these residents reported urinary incontinence, which was the most frequent of any of the symptoms listed here in this chart. And I just want to point out, we give a lot of thought and consideration to treating and management of pain. And you can see that pain is down here. And so many more individuals experience urinary incontinence as a burdensome symptom. So something that we really do need to pay attention to. And the study went on to also survey healthcare providers in the same facilities. And these providers ranked urinary incontinence as a moderate burden compared to the residents themselves, who ranked incontinence as one of the most burdensome things that they deal with. So just want to point out that there is this discrepancy that as providers, we don't tend to think naturally as of incontinence as being among the most burdensome problems for these individuals. So we can take the slides down. We're gonna approach this section a little bit differently because of course, when we see people for urinary incontinence, we don't typically refer to palliative care for that reason. So instead of doing a case-based analysis here, Dr. Lorenz, and who we heard from earlier, a palliative care physician, and I are gonna have a conversation about this problem. And I think it's really important to start by pointing out that oftentimes as urologists or even as palliative care physicians, as doctors, we're not the ones on the front lines helping to care for these patients, right? It's oftentimes the nurses, nursing aides, oftentimes the family members and other caregivers. So I want to start off by acknowledging that very important piece of this. So to start, Dr. Lorenz, as a palliative care physician, I'd love to hear from you. Do you see this as a major problem in terms of management of urinary incontinence towards end of life and in palliative care? And really, what is your experience with this?
You're right, Anne. First of all, that we do see it commonly as patients lose cognitive function, which we all inevitably do before death. It's a problem. 2/3 of Americans experience serious disability in the last 1 to 2 years of life. And so frailty and an inability to physically navigate to a toilet is another really important contributor that many of us eventually succumb to. But I think you've rightly pointed out that it's a significant issue in urology. I mean, women, yes, and also men, right, in the treatment of prostate cancer and other diseases of the pelvic floor. So there are many reasons that we have incontinence, and it's, as you rightly said, it's a huge burden, and one that as physicians we play a role in alleviating, but the burden often falls on our caregivers, both professional and personal. So what, from your perspective, are major considerations in caring for urinary incontinence?
Yeah, so a couple of things. One is as doctors, we always want to fix or treat a condition. And oftentimes in this setting, it's not about treatment. It's more about sort of management of symptoms and comfort. And the other thing I want to mention is the concept of dignity. And really, as physicians, we may not think first about dignity, but in terms of urinary incontinence and the treatment of this problem, in addition to many other problems that our patients have, dignity is really a core issue to this. And I want to emphasize that. And, if we think about the Declaration of Human Rights definition of dignity is all human beings are born free and equal in dignity and rights. And this applies to everyone, right? Regardless of cognitive capacity or agency. So kind of starting there. And then I'd like to also mention there's a Canadian psychiatrist and scholar by the name of Harvey Chochinoff, who's done a lot of work in defining a dignity model for healthcare. And one of the things that he has highlighted that I think is very pertinent to this problem is that dignity can be easily lost when the body is unable to be controlled. And that's exactly what's happening with urinary incontinence, right? Where individuals with incontinence are unable to control their urine, they're unable to control their bodies. And this is, a direct affront to dignity in many cases. So I think that the two are intricately involved, intertwined, and it's really an important feature to think about.
I'm so glad you mentioned Harvey Chochinoff. He's done tremendous work in this area. And in 2002, he explored this model with 50 cancer patients in Canada. And several things that came out as themes in his work that I think are relevant to incontinence include the fact that patients feel dignity is promoted by maintaining their independence, by maintaining roles in relationships, by minimizing the burden that illness places on others, and by maintaining privacy and personal space. And you can imagine in incontinence that the embarrassment of it and the occurrence of it prevents people from being independent, that it can interfere with maintaining roles in relationships, both broader social relationships that might be related to that, but also issues like sexuality and the embarrassment of being incontinent during sexual relationships. The issue of placing a burden on others who have to clean you, and the invasion of privacy that can represent, especially when caregivers are of a different gender, and and if that's important to you, and also when they're unknown to you, right? Because they're professional and could be rotating in and out of your care. So there are many ways in which that model helps us really think about these issues our patients are facing, and then how we ourselves as clinicians may need to do different things, like assess the gender preferences of someone, understand how their religious identity may impact upon the choices they make and their use of their need for privacy. So that becomes very, very important.
Yeah, absolutely. And cultural influences as well, right? I mean, there's so much, you've made so many good points, and there's so much to unpack in what you've just said so eloquently. We could really spend an hour or more talking about these issues. One thing I just want to highlight is you touched on relationships, and Renata so eloquently spoke to this earlier in her essay and sharing her experience. And there's so many different types of relationships to consider here, right? So there's the relationship between a close family member, someone who's close to the individual and what they're going through and having to help manage the situation that's very personal, right? And very intimate. And whether that's a spouse or a child, I mean, there's a lot of nuances to either side and all the dynamics involved in that. And then on the other end of the spectrum, a lot of care is being provided by nursing aides, nurses, other types of healthcare professionals who are complete strangers to the individual. And that presents a whole other set of issues. So there certainly is a lot there, a lot going on, and a lot to consider in caring for these individuals with these very sort of intimate and charged aspects of their lives. So I know we're running short on time, but I just want to ask you one final question here. So what would you see as the role of the urologist in the context of helping to manage patients with urinary incontinence and palliative care?
As many speakers have pointed out, urologists have long-term relationship with patients they care for. And that means that patients trust us as providers involved for the long haul and helping them to navigate these issues. I think we need to be sensitive to incontinence and cleanliness and all the attendant issues in a range of urologic conditions. Prostate cancer, of course, being one that affects men. Benign prostatic hypertrophy, when treated with surgery, right, can result in incontinence. So this is the issue of incontinence and cleanliness is one that's pervasive, and I think that's important to remember.
All right, thank you. Dr. Bergman, we'll throw it back to you for questions or for
This is John Gore. I'm actually going to introduce Dr. Darson, and then we're going to move on to some Q&A at the end. Dr. Darson is joining us with experience that spans several different roles. He's had numerous roles within the AUA as a senior physician with Arizona Urology Specialists, including chair of the AUA Practice Management Committee. He's a member of the AUA Coding and Reimbursement Committee, and also serves as a liaison to the AUA Quality Improvement and Patient Safety Committee, which is chaired by Dr. Nielsen. Dr. Darson is a general urologist with interest in BPH and minimally invasive techniques to manage BPH, and he's going to talk to us about general urology cases pertinent to the palliative care patient. Thank you so much, Dr. Darson.
Good morning, and thank you for the introduction. I'd like to thank Dr. Nielsen, Dr. Bergman, and Dr. Gore for allowing me to be on this panel. It's an honor to present with everybody else. I'm going to just discuss a general urology case. And I want to start out by saying I'm not endorsing use of any specific medications or medical devices in this. Really, this example is more to illustrate the number or the numerous points of contact that urologists have with a patient with voiding dysfunction and some ultimately terminal life disease process. So this is a 70-year-old male with a history of BPH and Parkinson's disease. At 62, he was placed on tamsulosin for an IPSS score of 15, which then improved. At age 65, the irritative symptoms started increasing. He was placed on oxybutynin, 10 milligrams ER by his PCP. At age 67, he was ultimately referred to urology as his Parkinson's progresses and symptoms progressed. The oxybutynin was discontinued. It was elected to do a workup for bladder outlet obstruction because a lot of these folks with Parkinson's, these 65, 70-year-old guys, are also guys with bladder outlet obstruction that can be treated successfully. So he had a urodynamic cystoscopy and a truss. He was diagnosed with bladder outlet obstruction, and he underwent a minimally invasive treatment for his BPH. And 6 months later, his IPSS score went from 20 to 8. Over time, his IPSS score increased. Urinary incontinence started. Mostly in these cases, it's urge incontinence. Pelvic floor physical therapy was initiated. Posterior tibial nerve stimulation was initiated. He was started on mirabetrol 50 milligrams. All these things improved his condition. Over time, the Parkinson's continued to progress. Mobility issues set in. Urinary incontinence progressed. And what I see a lot is significant others are the only caregiver. It becomes very difficult for them to handle all the different aspects of the care, specifically increased laundry from the incontinence. And over time, I've seen that the health of the caregiver is ultimately impacted by the patient's disease process. So in this example, I'd like to go ahead and answer the 4 questions. First of all, when should palliative care be initiated? As the other panelists have pointed out early on, my philosophy is load the boat. As many people as I can get involved in the patient's care to improve their care, I want to do that. What aspects of palliative care can a urologist implement? Well, I think being vigilant, say, using medications as an example. When one is tried, making sure that it's assessed whether it's a success or a failure, combinations moving forward. I also think individualized care for each patient is very important. And what I mean by this is constant reevaluation of the care given to that patient, what's working, what's not, and also what is the patient's status and how much is their overall condition progressing. And I think importantly, from a practice management standpoint, making sure that the office is easy to navigate for the patient and the significant other or caregiver. What I've found is a problem in my own practice at times is a patient will have another medical appointment. They miss their appointment with me, and then all of a sudden I'm booked out a month and I don't get to see them again for a month. And I think that's an important area where we can really impact in a positive way the patient's condition. The third question is, what aspect of palliative care is best implemented by a palliative care specialist? And I think, again, overall care coordination is very important. There are many aspects to comprehensive care for patients like this. And also communication with the patient, the family, about the prognosis, and keeping them aware of what all the options are in the future, I think is very empowering to both the patient and the caregiver. And then the fourth question about what other specialties should be involved, pain management, physical therapy, occupational therapy, and social services are all key in a situation like this to optimize the patient's care.
Thank you, Dr. Darson. That was so illustrative of the needs that we have in urology that are really unmet at the moment, and hopefully we can figure out how to meet them better. We have a lot of Q&A questions. If it's possible to get all of our speakers back on the screen, we will rapid fire you with all the artillery we have. Awesome. One of our first questions for the Stone panel for Dr. Pearl, Dr. Leppert, and Dr. Scales was, Stones are sometimes found incidentally while evaluating for other serious conditions like cancer. And when patients are undergoing primary treatment for those conditions, how do you approach managing those stones?
I guess I could jump in on that. I think you really have to look at it in the context of the stone. If it's an asymptomatic stone, it's non-obstructive, so it's not causing pain, it's not causing infection, then there's no reason to even consider intervention at that time. I mean, that doesn't mean that there still can't be proactive measures taken to, monitor the stone, even evaluate for risk factors and ways that you can prevent the stone from progressing. But fortunately, in an asymptomatic, non-obstructing stone, surgical intervention doesn't need to be considered, especially at a time when it would be inconvenient.
We had another question, Dr. Susskind, to you about the current state of communication for your complex patients who have incontinence and other problems. As far as communicating with the other clinicians, how does it currently look and what could be better?
I think this is a general question that probably could be asked to all of us. So I think that there's always, room for improvement in communication, right? It's obviously easier to communicate, at least for me, with other physicians and providers within my healthcare system. And it gets a little bit more challenging where people are outside of the system. But, we do what we can do to make it work. And I think also just in my experience and talking about these issues, a phone call works so much better than an apex message or an email in kind of fleshing out a lot of these complex care issues.
Dr. Gilbert and Dr. Jacobs, we have a question that came in for you about cultural appropriateness and whether you have to change the way you manage these patients and how these discussions happen based on different cultures.
No, I think that's an important point. So depending on a patient and their caregiver's background and what's acceptable in their culture, I think it changes the approach and discussion to a great degree. And that's one thing I don't feel that we get great training at in residency or fellowship. And it's just kind of bubbled up into the forefront over the past few years. I think a lot of cancer centers are fortunate to have a diverse staff and translators that can help kind of read into subtle scenarios and kind of cue the doctor on what might be appropriate, what might not be. So I think we're on that learning curve.
Yeah, I would agree. The only thing I would add is, I always try to encourage the patients to bring, their spouses or whatever friends or support that they have to the appointment, because sometimes having them there can kind of add to that context and give a better sense of understanding and what direction they want to proceed in.
I think that's also the huge benefit of doing these discussions earlier on so that the patients have time to digest it, they can bring their family in, and it's not a rushed conversation when all of the issues are hitting the fan. Dr. Darson and Dr. Lorenz, we got a question for you about pain control and palliative care. Dr. Darson, from your perspective, how do you choose to refer to one versus the other, and who is really the best? A lot of these patients who have advanced disease have both problems. They have pain and they have palliative problems. How do you triage who to send them to? I loved your idea of loading the boat because that definitely seems like the best answer. So do you just load it for everyone? Do you do it selectively? And Dr. Lorenz, what is the best way?
Well, for me, I again try to individually assess each patient, and whatever I can whatever person that I can invite on the boat to help the patient is who I invite. And a lot of these patients do have pain, not necessarily from their urologic condition or in this case, Parkinson's, but they may have other issues as well. But that's kind of how I do it.
I would just say that the distinction between involving, say, a pain management specialist and a palliative care physician is a little bit of a false one. And what I mean by that is, I think I don't really know, and I'm not sure that there's research that gives us good insight, but I do feel in my clinical experience that sometimes we underutilize interventional pain procedures. And, this may be especially important in the pelvic floor, for example, in certain kinds of pain. And then, the other issue that comes into play, if the patient is still receiving, care with curative intent and is having significant symptoms, there's benefit to addressing these issues. And we also may be trying to minimize opioids because, actually, in many post-operative situations, for example, right, minimizing opioids may minimize long-term use. So in some states, for example, have taken measures to be very proscriptive about that. So I think there are reasons to not think about this as a uniform task of either service. In my clinical experience, we've often negotiated the specific roles that will play in the hospitals I've worked at, say a pain specialist versus the palliative care team. But I think this is why this is a Big Ten issue. It's not about a small cadre of urologists or a small cadre of palliative care physicians, et cetera. It's about finding collaborative ways to work together with patients and address their needs, and not just physicians either.
I think as efficient surgeons, we may actually end the conference early. But Dr. Gore and I just wanted to say a huge thank you, first of all, to all of our speakers and panelists. We're fully aware of what an incredible amount of time it took to prepare the talks and work through them, and especially with this format. So thank you, thank you, thank you. And we're so excited to work together moving forward. To Karen and Caitlin and Emily, you've done 10 times as much work as any of the rest of us getting this prepared. So thank you to you. And then to all of our participants, just a reminder that this is really just a building block onto the actual in-person QI Summit on September 13th. So please pass the word along to everyone you know about the Monday, September 13th in-person summit. For all of your residents and fellows, there is a travel scholarship that they can apply for. And we're super excited to continue this work together.
Thank you, everyone.